interesting to me because this one was published 2016. There's another one that came out in 2019. There's another one coming out this year, but the data have stayed about the same that we'll talk about. But they look at pretty much any disease process worldwide, and they start determining a couple different things. Number one, what's the cost of these disorders, the prevalence of these disorders, especially in terms of causing global disability. Right, so these are worldwide data, right? They looked at, 25 years with a lot of smart people looking at the data. And I always bring this up, especially when I have students in the room, because anytime a student completes a research project, amazing, by the way, project, I'm shy, because I'm going to say those. That's right. Sample size is always a little too small. More research on a larger sample size is going to be indicated. I just want to include you in here. This had 9.3 billion patient estimates over the course. That's why I said that would suffice. 9.3 billion episodes. And so, some of you may have seen this data, but if you haven't seen the data, what disorders do you think would cause the most disability worldwide? And this looks at over 300. So you named it. Cancer, cardiovascular disease, musculoskeletal, skeletal problems. Right? If you haven't seen the data before, what disorders do you think would cause the most disability worldwide? Just curious.
Worldwide?
Worldwide. We're talking about sub-Saharan Africa.
Yeah.
Here's the data. Here's the data. And so it's like the old David Letterman top 10 list, right? And so along the top, right here, your top 10 disorders, and then this vertical axis here has age. And so the number one disorder, if we start to get into folks that we typically see, 20 to 24-year-olds, number one cause of disability worldwide is depression, followed by back and neck pain. And then if you start looking at 25 to 64, it's back and neck pain, then they can't think about it anymore. They can't sense it, it's still back and neck pain, and then even if they throw some Alzheimer's in there, they still get back and neck pain. Right, so it just surprises me that you think about the number one cause of disability worldwide, it would be back and neck pain, and followed by depression, right? Because depression is an extremely common comorbidity we've already talked about, a little bit. Right, and so, and I'll just mention this, and we'll talk about it a little bit more, but if you're not screening for depression in your patients, you should be. Right, and I'll even go so far as to say, even begin to screen for things like fear avoidant behavior, and, catastrophizing and coping issues and things like that. We'll talk about that, because if patients have a true depression comorbidity associated with their condition, what's the likelihood of you getting them better? The average low. Very low. But if that depression is related to their musculoskeletal complaint, like if I get your knee better, let's say you tear your ACL, you're immediately be depressed. Right? So even if you see them, they're depressed. If your ACL rehabs, you're 100% back to full go, you'd be depressed. No, that's not you. Right? You could say, maybe I need to intervene with someone else, right? Or do you want to see someone else? We'll talk about that. Unrelated to their condition, even if I'm 100% better, I'm still depressed. They're not being managed by someone, they have to be depressed. Okay? So we'll talk about that a little bit more again probably tomorrow. But I don't know, is anybody surprised by that? With all the other things kind of going on, And so, what do you think the colors mean? The colors mean that if it's green, over the course of that 25 years, it's gotten better. The outcomes have improved. And so, if you're dealing with kids with anemia or acne, that's gotten better. Right? If it's yellow, it means it stayed about the same. If it's orange and getting red, that means it's getting worse. The outcomes have worsened over the course of the past 25 years of that age. And so, it's really, really red from 60 to 64 years, and it backs off a little bit. But why is it so red up to 60 to 64 years? What's happening at that point, 64 to 65, where it backs off a little bit? Retirement, that's right. These are folks who are trying to get to the finish line. right? Try and get to the finish line. And the one thing I'd say to you is that, you know, you're not gonna go to a course at CSM, you know, or go to AON and hear about someone telling you that low back pain is really, really prevalent, causes lots and lots of problems, and we have no idea how to manage it. No one's gonna tell you that, but I'm gonna tell you. Because this is what the data support, but no one's gonna tell you that. No one's gonna tell you that. And so, the other thing that comes up with this is cost, okay, cost. This is in 2013. Low back pain was third, right, behind diabetes and heart disease in terms of cost. This data is from 2020, 2016, and musculoskeletal disorders have now become the most costly disorder to manage, well beyond non-communicable diseases like diabetes, cancer, and cardiovascular disease. And so I looked this up last night. $380 billion being spent on musculoskeletal disorders in this country. Of that, 134 billion was spent on low back pain. 134 billion. So I tried to break this down and figure out how much that would be each minute in this country, 24/7, 365 days a year. So each minute in this country, $254,000, $250,000 is being spent on the management of low back pain.
Treat it out.
What's that?
Treat it out.
With outcomes that ain't that great. I found that, I look at that number, I'm like, this is not, this is not. And I'll say this, of these patients here, right, how many of these are you guys seeing? If we look at PTs, so all the ICD-10 codes with patients with low back pain, how many actually get to a PT? Do you guys actually know that?
I don't know what the data is in Kaiser. At one point, but this is the late 90s, it was 22%.
That's pretty good.
Yeah.
That's pretty good, because normally about half of that. Normally, if you look at big groups, even like a place like, you know, Intermountain Health, we've looked at data from the Mayo Clinic, it's usually about 10%. This is a question I have, I know Kelly and Michael were underwhelmed with Dr. Chow's talk at AON.
I wasn't underwhelmed. I knew he had more to say, that's all.
I know. So, Dr. Chow, who is, if you Google Dr. Chow, he's the most mild-mannered man you'll ever meet. I have no idea how he does it. He sees like patients 20 hours a week. And he's on top of all that research. So he's the most published researcher in terms of low back pain. I've heard him talk twice. I have said him in Salt Lake City about 10 years ago, because I asked him, I said, well, should you be sending more patients to PT than we're getting? And he said, no, because we don't even know who to send to PT, and you guys would be overwhelmed with it. So anyways, I caught him at AON in the back of the room. I don't know if you saw me go and talk to him.
Yeah.
I said, just have a couple questions for you. Can I, you know, I can ask him right now, is there a chance I can sit down with you about maybe buy you a cup of coffee? He goes, no, but I can use a glass of wine. So I got his ear for about a half hour. And I got some really interesting information out of it. And I said, is this real? He goes, trust me, it is definitely real. It is definitely real. He said, these hospitals are in crisis with managing musculoskeletal disorders, primarily low back. They're in crisis. And they don't know what to do with it. Don't know what to do with it. Of all this money being spent on PT, or I'm sorry, all this money being spent here, how much do you guys generate out of that? Give me a percent. How much comes out of you guys for PT? Let's say that. How much is PT part of that bill? Because we got some ball games today. I'll put the over under at 10%. I'll put the over under at 10%. You generate more or less than 10% of that 380 billion. Less. Probably somewhere between about 2 and 5% that PTs are actually contributing to that. Right? So what do you think is contributing to that? Because you guys aren't getting that money, are you? You guys aren't getting this. What do you think is contributing to these costs and these poor outcomes? Imaging, right? Got the next slide dealing with imaging. So you guys go ahead and take a look. I love it. That's great. Go ahead and look. Perfect. But imaging is definitely a major concern. Because imaging, know, especially with these magnets now, you're definitely gonna find some. And you guys get, I don't know, how many, who's seeing patients with low back pain in the room? Patients with back pain. In fact, there were some hospital-based therapists here too, people doing other things. So I didn't know, so of you who are seeing patients with low back pain, what's your average number of visits for somebody with, let's just say, subacute to chronic low back pain? You guys know that? Like how many times are you seeing that person? And over what period of time?
It's 5.5, Mike.
5.5
5.5 visits.
Yeah. Over the course of what you said, you know how long?
It's episode of care, so it's a 6-month slice.
Okay.
Yeah.
Very good. About 5 visits, very good. But like I said, you guys aren't generating a lot of that, right? You're not getting it back. But the diagnostic imaging, and say you see your patient for those 5.5 visits, and they're not better. They go back to the physician, and I'm asked this all the time, what am I supposed to do? Because we teach at 2 medical schools, right? One medical school, get this, they get 8 hours of musculoskeletal, 8 hours. It's taught by me and another PT. He does extremities, and I do spine. They get 8 hours in their curriculum.
That explains a lot.
And I'll show you data this afternoon that about a third don't have any, believe it or not. Our PA program, you know, they just don't, it's not something that they think about, because there's other things that they need to have covered. But when they leave, and the reason it started at this one med school was because they brought on an internal medicine physician teaching physical exam, and she was a gal who's been in the trenches. And she knows that you're gonna see a lot of low back pain. And if they don't know how to treat it, what do you think they attribute all that low back pain to? These are people who are drug seeking, right? This is drug seeking behavior 99% of the time. That's the attitude that they have, which is terrible, right? Well, let's get this a little bit more. So imaging is certainly a factor. You're finding pathology. If you're dealing with that biomedical model and fixed pathology, patients are going to get better. I'm going to show you a couple things. We'll talk about imaging just for a little bit here. So I like these infograms here a little bit. These infograms are kind of nice because if you start imaging patients, again, who are asymptomatic, you're going to find stuff that looks like it matters, right? And the spine probably has the highest rate of findings that are concerning in asymptomatic individuals. If you start to look at these ages as people begin to age, right, there's been a little bit of a push. This has also kind of gone through AMP a little bit too. We'll talk more about the significance of this. And these are probably normal age-related changes, right? Instead of things like degeneration, putting terms on this. And again, we'll talk more about that. But trying to just change how you talk to patients, you know, in terms of their imaging findings. Now, it's up to you to figure out the significance of it. Because you could have a patient, you know, who has a hip, right? And we got here this study, 54% had labral tears and they're asymptomatic. Well, if they have a scan, right, and they have a labral tear, it's up to you to determine, is the labral tear significant or not? Right, and that's sometimes hard to do, right? So that's one point here. You know, and we talk about this a lot too, that when patients know about these imaging abnormalities, it can definitely affect their psyche. It can affect their ability to move. It can influence fear avoidance, again, depression, right? And so putting these findings in the appropriate context matters. Interesting paper here, published a couple years ago. So these are patients who had low back pain, mechanical low back pain, all had scans of their lumbar spine, MRI scans of the lumbar spine. One group just got what you normally see from a physician, meaning that they got the report, you have a herniated disc in your back, and that's the cause of your symptoms, what people would normally do. The other group got this kind of attack, okay? So you have to figure out, is it normal age-related changes? That's probably not a huge driver in terms of what your symptom profile is. That second group got that kind of thing, and we'll talk about that, right? That these are normal age-related changes. They're probably not significant. There's other things that we're going to do that are probably going to get you better beyond what your imaging results show us. You guys good with that? So here's the data. Just looking at 6 weeks after the MRI. Looked at 4 different domains here. The first one was reductions in pain. The orange group is the group that got that approach where these are normal age-related changes. We're going to place them in the appropriate context of your history and physical exam intervention, etc. So pain significantly diminished. This is their perception of symptoms here. This improved significantly compared to the other group. And then this is SF12 data. So SF12, SF36, these are typically research forms that are done that look at physical and mental well-being. And so you can see this is physical health right here. That improved, and here's the emotional well-being as well. That improved too. So just with that couple of minutes of just helping the patient understand what those imaging findings mean really matters. Now, I think we can help with that a lot, right? We'll talk about lab results tomorrow, but having an understanding of what those imaging findings are and taking some time to discuss them with the patient, right? And there's certain patients that probably need that more than others, right? So if they have yellow flags and they have imaging findings that show what's quote-unquote pathology, right? That's probably one of the reasons that they're concerned, right? And again, it's up to you guys to determine what the significance of those findings are, and if you can have that talk with them. So there's a push along the United States to try and get physical therapists to order diagnostic imaging. We're probably up to 12 states now that have, no kidding, PTs can order diagnostic imaging, get it reimbursed, the whole 9 yards. Okay, there's probably about 12 states right now that have that. So this is always something that I'm kind of interested in because I teach diagnostic imaging as well and trying to figure out, what do we need to be teaching people. So this particular study looked at, I want to say this is close to 5,000 physical therapists that were surveyed through a bunch of different states. And what we wanted to know was, because this is what you hear from the legislatures, is that, number one, you're not trained to do diagnostic imaging, right? And number two, you're not doing any of the skills that are needed, right, to actually know when patients need imaging. So we came up with these 10 skills that you should probably be doing, right, to refer a patient for imaging. We want to know how often are these happening with PTs. And so when you start to see these infograms, right, PTs are routinely performing these 9 or 10 drivers of skills, right? They get something like this and they put these things together, push this out, that PTs are doing these skills routinely. If you look at the actual data, there's two areas that when I look at this say, we probably have to pump the brakes a little bit. Like there's some areas that we could probably do better in. So if we look at this here, skill 2, only 62.84% said they're routinely doing skill 2. And then only about half said they're doing skill 5 routinely. Now those two skills are utilizing evidence-based imaging guidelines. And then skill 5 is knowing what imaging modality to suggest. And if I'm doing plain films, what views to suggest. You guys follow me? It's two pretty big areas. I'm not sure when I should get it done. And I'm not sure what modality I should get, even if we're talking about plain films. And these studies are always really skewed. I don't know why. I know with COVID, we couldn't do a lot of patient care research, we did a lot of survey research. These numbers are always skewed. I haven't looked at this, but you start looking at these, like half of these folks have their OCS, they're board certified. So these are a different population, normal PT populations. I don't know about you guys aren't probably normal PTs here. You're on the high end, but I think it's like maybe 5–10% of PTs at board certification. These studies, we always get like half of the PTs who are board certified, so it's a skewed population. So if that population is telling us they don't know what imaging to order, right? And when to do it, that's a concern. And so, again, just think about this. When is imaging really needed, right? So, concern, right, over a fracture, bony alignment, or integrity. So fractures, there's 3 really nice rules out there that you guys should know, right? Canadian cervical spine rule and Ottawa knee and ankle rules. Those help to determine when imaging is needed. Now, those rules, right, if you use them, right, you're likely, they're not, let me say it this way, they're sensitive, meaning what? So what's the Ottawa ankle rule? What's the Ottawa ankle rule? You're looking at gait, and you're looking at palpation, right? So you're going to palpate the medial lateral malleoli. You can also go down the foot, palpate the base of the fifth navicular, right? And if there's fracture quality, pain, and tenderness, you get an image, and there's trauma. Or if a patient can't bear weight, right? They can't bear weight, you get an image. Now, those rules are all designed to be sensitive. Sensitive. So what does that mean? The rules are designed to be sensitive. We used to do this talk, we don't do it anymore. Sensitive specificity, but what does that mean? The rules are designed to be sensitive. So all three of those rules are sensitive. Meaning if they're negative on the rule, you can proceed with confidence that a fracture is not present. So if I can bear weight, even with a limp, I can bear weight, and I do my palpatory exam and I don't have fracture quality pain and tenderness, I can move on without film. And a fracture is likely not going to be there. They're not specific though, meaning that just because a patient can't bear weight after an ankle sprain doesn't mean a fracture is caused. They're made to be sensitive, right? If you look at the names, why are they always coming from Canada? Think about what that tells you. I can, for emergency room physicians, I can proceed with confidence that I don't have to get imaging. That means I'm not spending money on unnecessary imaging.
Socialized medicine.
Socialized medicine. And Pittsburgh kind of thinks they're Canada a little bit too, because they come up with their own rules like that too. UPMC, they're kind of up there, providing high quality care, so they came out with some rules like that too. But bottom line is, if you have concern with that, right? If you have patients who have these red flag findings, we'll talk more about those, but malignancy, infection, inflammatory disorders. If they have pain, and they have constitutional symptoms associated with it, and that pain is really, really bad, right? Go ahead and image them, right? Constitutional symptoms, what do you mean by that? Something like fatigue, fever, drill, sweat, weight loss. Start thinking about maybe an infection, right? Something associated with that. If they have any concerns over bowel and bladder issues, we'll talk about that a little bit more too. Objective neurologic deficits, especially progressive, right? And then lack of we'll talk more about that, but that's always one that's a little sticky. But the bottom line here in terms of what is the gold standard are these American College of Radiology appropriateness criteria. Now, is anybody familiar with these? Anybody familiar with these? It's not an imaging course, but I would tell you, maybe if I can get online, I can show you some of this and how this works. But this is really the gold standard right now for when diagnostic imaging should be done and what modality should be done as well. Okay? And so again, we'll probably talk more about this, but this is probably the gold standard right now. And when we talk about, when we go back and talk about this, I just want to mention imaging a little bit, how you speak to patients about it, placing it in the appropriate context, understanding that, you know, we see a lot of these findings in asymptomatics and really doing your due diligence to determine if they're important. Let me go back to this for a second. If I was to ask you guys, who has more responsibility for the fact that they're not getting better with back pain? Is it more on the patient or more on the provider or both? If it's on the patient, you would say that patients are generally pretty non-compliant, their lifestyle factors aren't that great, there's things they should be doing that they're not to prevent or manage their low back pain. How many of you think this is on the patient? Interesting. How many of you think, well, if you don't think that, does anybody think it's on the provider? You gotta pick one or the other here.
Both?
But I'm gonna put the over under 50. Who's more responsible? You guys are blaming it on the patients. It's probably a little bit of both, a little bit of both. But the next few slides I'm going to show you suggest that we probably aren't doing the best we can with the management of these patients, all right? And so I already told you, you guys are only seeing about probably maybe 10%, maybe 20% of these patients with low back pain, so the rest of these folks will be managed by somebody else. And if you don't know, right, there are clinical practice guidelines that are out there, right? In this particular study, just looked at, right, these worsening trends in the management of low back pain and why. And so they want to determine, are the majority of patients being managed according to these guidelines, or are they receiving what we call guideline discordant care, where it's the opposite of what we're telling people to do. This is for basically, this is for acute, non-specific low back pain that's mechanical in nature. So this isn't red flag type stuff. And the guidelines typically suggest self-care, education, use of non-steroidals or Tylenol, and then PT. But avoiding early imaging, avoiding opioids, and avoiding specialty referrals. When you look at the data though, okay, so this is referrals right here. And if you look at those lines, it's a little difficult to understand, but referrals to PT over this period of time went down 20%, while referrals to specialty physicians went up 20%. There's no reason to send a patient with mechanical low back pain, especially acute, to a specialist, but this is happening. This looks at opioids versus NSAIDs or acetaminophen. And so if you look at this, the opioids have gone up, while NSAIDs and acetaminophen have kind of gone the opposite direction. And on top of this, right, 60% of these patients were getting some type of advanced diagnostic imaging. So this is what this guidelines discordant care relates to. They come and see you guys first, they're going to get a much different course of care than being managed by a primary care physician. Okay? Because PT's in those guidelines, and I'll show you the most current clinical practice guidelines for low back pain today. And so this speaks to here, this overutilization of diagnostic imaging, which we all know is a problem, right? Imaging is probably happening too much in patients who don't need it. Very interesting study that was an eye-opener for me again, because in this particular study, which is a systematic review with a meta-analysis, so what this means is that this group of researchers take all the studies that look at diagnostic imaging, look at all the data, right, and then they make some clinical judgments on the data that they have. So taking all the studies combined. And so in this particular study, 35% of patients had imaging inappropriately ordered, meaning that there was no reason to get imaging, but they got it anyway. So about a third. The eye-opener for me was in patients who needed imaging, because they had red flag findings, only about a third got it. So in this case, 2/3 didn't get it. It got me. So I don't know if it's overutilization, underutilization, or both. But either way, it's not good. So again, when I ask you about, who you're going to put the blame on here, this part says maybe it's more clinician-driven than anything else. I'll give you another example. Right, so how are we doing in care of diabetes? How's diabetes out here at Kaiser Freetown?
Pretty good, given our patient population.
I shouldn't ask you guys this, because I take the studies out, it looks like I'm sucking up to you guys, but I put lots of studies in by you guys. You guys do things a lot different than a lot of hospital groups do. And so you guys are actually making strides in terms, correct me if I'm wrong, with things like blood pressure control, diabetes control. Yeah, and you're looking at these ethnic differences, racial differences, and you guys have eliminated a lot of that here, so I applaud you for that. But in general, looking at this, if you had to say how we do with diabetes control worldwide, it ain't good. And you'd say, well, who do we blame that on?
Lifestyle choices.
You blame it on the patients?
That's what I'd say most people would
Blame it on the patients. So if I was going to go, what % are we blaming the patients, what % are we blaming the providers for diabetes? For this?
Well, I come down to
What if I go, who doesn't know?
patients.
Patients don't know?
Yeah, they're just getting bombarded by all kinds of things that impact their choices.
70-30, how about that? 80-20, 80% patient cause, 20% providers? You want to go 80% providers problem for
Maybe not
this?
80, but let's say 60-40 provider.
Provider.
We've got the training and the knowledge, and we should be
All right.
very more to educate.
Very good. Look, I have no skin in the game with any of this. I really don't. I have no skin in the game. I don't align myself with any particular groups, politically or PT-wise. I'm Canada, essentially. Switzerland. All I'm here to do is present the data to you. I have some opinions, but this has been data-driven so far, would you guys say? This is just me. So anyways, you know, I do a research study.
Mike, in our facility, this is what we pride ourselves on.
Yes.
Right? These people get sent they get phone calls from health educators, their physicians talk to them about it for a minute. That's the problem. The information gets delivered, but it's like, you ask a patient, why aren't you taking the non-steroidal anti-inflammatory drugs that your physician told you about? I took it once, it didn't do anything for me. It's the same scenario with really everything that we do, that there's such a a very brief touch, even though the information is delivered, the value really doesn't come to the patient that way. And then we do have these backup systems. Health education's a big part of that. But we still get patients who don't understand the lifestyle changes they need to make because those touches aren't long enough. They're not high enough quality.
Yeah, so let me just say, I'll go back to this back pain business, right? So what I'm trying to propose to you is that there's probably things we can probably do better as clinicians and management, and we just talk about this, right? There's things we can probably do better. And how many of you have patients who are non-compliant with the recommendations you give? You know what I don't ever have anymore? Non-compliance with patients. Why? Because I asked them completely upfront, what are you willing to do? I have no expectations of anybody anymore in my life about anything. When I get home, cats are going to be hungry. My lady friend grandson's excited to see me. That's about it. That's the only thing I know that I expect in my life. But I don't even have these conversations anymore about you being non-compliant. Because I have patients tell me, I'm not, I want to know, what are you willing to do? And if you're not willing to do anything, I need to know that up front. Because that's going to help me work with you with whatever constraints I have. Right? And maybe we can help you become more compliant by having a conversation about why these things may be important. But I don't have patients tell me they're not, because I hear that all the time. They're not compliant with what they're doing. Well, I understand you guys are busy, but there's certain things that we need to spend probably a little bit more time on, and that might be one of them. Right? Finding out what patients are really willing to do. Are you willing to quit smoking? No. Well, I'm going to tell you the ramifications of that. In a nice way, right? And you guys are all nice. How satisfaction rates have to be highest amongst all providers, PT typically?
Yes.
Yeah, you guys are caring, empathetic people that patients like to hear. I'm being a little bit harsh right now, but you have to find out what patients are willing to do up front. Because a lot of this is on us. We're doing the wrong thing, patients don't get better. Bring up the diabetes thing again. And so this is a study that was done with Johns Hopkins physicians. Now, think about this. What's the importance of risk factor screening for folks who are diabetic? What's the importance of risk factor screening at home? Prevention. Is prevention important? Why are you guys doing this stuff? Is it just because Kaiser's altruistic? You just love your patients? No, because if you can lower blood pressure, lower hemoglobin A1Cs, what does that do to your bottom line?
Reduces downstream costs.
Exactly. So I'd love to say that you guys are altruistic, you love your patients. No. You have really good administrators who know what the downstream costs are going to be if you let this turn into hell's bells. And you don't call your patients. And you don't follow up with them, right? Because there's lots of groups that are doing that. You got the data to show it. So anyways, Johns Hopkins, I'd say, pretty good group of docs. It's like number 2 or 3. All they did was, this was at a conference, right? Probably they had a little bit more cal than coffee and cucumber water.
We got lunch coming.
Go into, you walk in, the guy with the chef hat on, little omelet bar, right?
Next time.
Mushrooms, red onions, put that off a little bit wet, because that's how I like it. Then they gave a survey. And the survey looked at how well do they know risk factors for prediabetes, how well do they know what the lab values are that diagnoses someone as being diabetic or pre-diabetic, what the management strategies would be. Like if you're going to recommend weight loss, what's an appropriate amount of weight loss? If you're going to recommend exercise, what's an appropriate amount of exercise to be doing? Johns Hopkins. And the way, because we redid this with PTs, because we had to start doing a lot of survey-based research during COVID. But we couldn't do patients, right? So we had to do everything with surveys, so we redid this study with PTs. The survey just had risk factors just listed out, and all the physicians had to do was just circle. And it had the lab values listed out with numbers. All you had to do was just circle them if you knew what the right number was. And so 6% of the physicians in the study could correctly identify all the risk factors. 6%. 17% internal medicine docs could identify the appropriate lab value to diagnose someone as being pre-diabetic or diabetic. I don't have it on the abstract. How many do you think knew what the appropriate amount of weight loss and the appropriate amount of exercise was? 25%. And when I redid it with PTs, I actually had to fudge the data a little bit. We actually did worse than this. PTs. Again, orthopedic group, PTs. I didn't fudge the data, but we had to look at the risk factors and things like that. It was actually less than 6%. So what does this tell you? And I'm going to get off this negative track here a little bit, but, you know, and again, I need to know what I should be telling you. So we're going to spend a fair amount of time tomorrow talking about, not a lot, because it's not that hard. Here are the diabetic risk factors memorized, right? Here are the lab values. So if you look in, right, your EMR, does this patient have a hemoglobin A1C that I need to be concerned about, right? Or do they have a fasting glucose that I need to be concerned about? Right? How much exercise should I if you're willing to exercise, how much should I recommend for you? And how much weight loss should you have? Right? This would be the goal. Right? It's not that much, like 5%, like 5-7%. Listened to a podcast this morning too, recent when I was exercising. It's the same type of thing for lowering the bad cholesterol as well. It's like 5 to 7% body weight. And so what this tells me though is that if they're not appropriately screening for risk factors, and they don't know what the risk factors are, you wouldn't know what would trigger the appropriate testing that would give you the subsequent lab results to begin to have the conversations that you were just talking about. You guys follow me? I would hope that wouldn't happen. But again, I'm pointing the finger back, and when you have, this is my take, when you have an outcome that's not optimal, take a minute and look at yourself and say, what could I have done different? And what could I do the next time I see a patient similar to you? That takes self-reflection. And I know you guys are busy and you don't have time for that stuff, but I'm going to tell you that that's what's important. That continues to develop you as a clinician. Okay? And so again, this is a study out of Intermountain Health. About 7% of patients with low back pain are being seen by this physical therapy department, Intermountain Health Law Group out of Utah. They're probably standing out of that. The other thing I want to mention too is that some of these populations now have PTs embedded, hospitals have PTs embedded into primary care. And we've had that here forever, for a long time, right? And so this particular editorial talked about some of these other countries that are now allowing PTs to order, not only order, but interpret imaging findings. Electrophysiologic tests, blood and urine tests, soft tissue, joint injections, prescribed medications, right? But to be able to do all that stuff, you got to be able to know you need to screen joints above and below. You need to be able to know what risk factors are, right? You need to be able to know if I'm going to stick a needle with a corticosteroid in someone's knee who's diabetic, what's going to happen to their blood sugar? Yeah, do you want to burn a relationship with the doc? Yeah, I'd like to have, an intra-articular injection for this patient who has a frozen shoulder. But you didn't tell them they're diabetic. And then their blood sugar spikes up to what, like 300-400? Right? That's how you start to ruin relationships with physicians, right? So you need to know some of that basic stuff. I gave you guys this paper here. Katie O'Bright, I think she talks about, presents a lot of really good data as to how some of these PTs are practicing at a higher level. You need to be doing some of these basics here. I just want to mention this real quick because these schools of thought do exist, and I give Michael credit for this slide. I think he put this together. I added a couple names to it and beautiful photos on the side. But I'm just going to say, if you align to one of these schools of thought, and a lot do, right? They align to one school of thought, and I use McKenzie as an example. So I don't know how much McKenzie is used out here on the West Coast. I don't get the impression it's that.
It's not as prevalent on the West Coast.
Yeah. So if you're up in New York State, we just had a McKenzie course at our facility. We have a bunch of McKenzie trained therapists, and they bring them into the student discount. 60 seats fell off overnight. And likely you seeing a McKenzie trained therapist goes up a lot. They don't manipulate, they don't do any strengthening, right? Their education is somewhat limited in terms of what they're really thinking about, fear avoidance, things like that. They do repeated movements, right? And all these are as well. What I'm just going to share with you is that each of these approaches probably have utility for the right type of patient, but it's not gonna work for every patient. I'll give you an example. I just saw someone who was seeing a McKenzie trained therapist, interesting guy. He was the husband of one of our students who just graduated. Former football player, college wrestler, rugby player, trying to train for a marathon was on his bucket list, right? And he's seeing McKenzie trained therapist. He had back pain. So the only way I get better is if I get down to crouch and kind of hold my knees together, right? So he's seeing a McKenzie trained therapist. What do you think they had him doing? Prone press-ups, right? Prone press-ups. And I just examined him just a little bit. He had a grade 3 spondylolisthesis in his back. That's what he had. And so how is a prone press-up going to respond? Or how is that back going to respond to doing that extension activity? Going to continue to get it worse. Now, why wouldn't they investigate that a little bit closer? Right? So you're pinning your flag on a particular approach. So I say use caution. And all this is just an example. And I'm not going to put the name up here. Another course that came to our facility because we're always looking for content to come to the community. This guy's going to talk about his wonderful 40-year odyssey with low back pain. He's going to present his 3E approach. And so all I said was to our coordinator of this education program, I said, does he have any, just asking, any data, any research that backs up any of this? And she just wrote to him, and he really was offended. You know, this is my clinical experience over these 40 years. And, you know, I'm coming to give you guys this knowledge that will really help you guys. You know, maybe he said some things that helped, but I think it's pretty ballsy to come in and present an approach that you've been doing and no outcomes. At least publish a case study or something that tells us what it's about. What do you think? The same. And so I know Christie's trip to Reno, circa 2003, was a lot of fun. John Tiny, was the keynote speaker, he's an SI guy. Everything's the SI. But the reason I bring this up is that, you know, we sometimes think that younger therapists who just graduated, you know, we got to keep a close eye on them because their clinical outcomes may not be that great. And the seasoned folks, right, like me, we have all the answers. Well, very interesting study here. Again, this is systematic review looking at clinical experience and quality of care. What do you think the relationship is? Again, this isn't me, this is published. I think this is Annals of Internal Medicine, which is probably like a top 5 journal probably in the world. The relationship between clinical experience, years of clinical experience, and outcomes. What do you think? So, older clinicians with more experience get better outcomes. Is that what you would think? That's what I might think.
You would hope.
You would hope. It's actually an inverse relationship. So providers who are practicing longer actually have poor outcomes. Now, why do you think that would be?
Burnout. Is it because they're getting more complex patients?
More complex patients and things change, right? Things change. You know, that's why I think clinical practice guidelines are kind of nice from a 30,000-foot view. Because at the very least, it gives you some indication of what you probably should be doing with your, or at least thinking about what you should be doing with your patient. Give you a good example, fear avoidance beliefs, right? When I went to school 30 years ago, I don't know if fear avoidance beliefs existed. You know, we thought they did. We didn't know how to screen and do stuff. But now we know that if patients have these yellow flags and they're not identified and they're not at least thought about being managed, right, the outcomes are probably going to be worse in those patients, right? So if you're not doing, right, basic yellow flag screening, right, to at least identify if this patient even has yellow flags, or you're at least not screening for depression, anxiety, right, if patients have those, you're probably going to miss the boat on a large number of your patients, right? So that's it, you know, basic. But I'll get off that picture a little bit. And so if you went to AM 20 years ago, this was a big buzzword, evidence-based practice. I think it still has a place, at least to think about, right? All of you are developing expertise, and it continues to develop over time, right? We want to use the best available clinical evidence, and that means that you should think about being a clinician scholar. That's what we want our grads to be, right? Clinician scholars, so they can come out, they're not probably going to do research, but at least they can answer a clinical question, maybe about a patient who's not getting better. Then they refer to the literature and see if there's something else out there that I could be doing. Then patient values and expectations, right? This is probably the most important that's probably coming out of everything that we're doing. I think it's a good example Michael talks about touching patients, reaching out to them, about some of these disorders that they may have that they're not appropriately educated on. You can change that behavior. You can. It's hard to do, especially in the context of everything else we have going on. And so I just want to talk about this for a second. So clinical practice guidelines are out there for the majority of these conditions that we treat. This is low back pain, it's right here from 2021. This is the most current division. You can look at these different grades of evidence here, and they come up with these wonderful tables, these wonderful graphics here. But if you don't want to read the 60 pages associated with it, you can break down what you should be doing. So this is acute low back, okay, acute low back. This is acute low back pain here. The evidence map is called, right? So what should you be doing for patients with acute low back pain, right? You should be doing thrust or non-thrust joint manipulation. I'm not just making this up. They're looking at all of the data, right, that's been funneled in. So if you're not putting your hands on patients with acute low back pain, you're probably missing the boat to some extent, right? Here, may use, right? May use, right? These are some things you may want to consider, right? Can use, etc. Where are these knowledge gaps? Now, if you're dealing with chronic low back pain, things are a little bit different, right? But when you start to look at these and you say, all right, when these patients with acute low back pain, things I should be doing for them, am I truly doing it? And it's easy to do. Look back at what you're doing. But I just want to put this up here because there are better ways of doing things for patients, right, that come out over time. How many of you read this paper? Read this paper. So this is interesting, and I never understood. I read this paper, I don't know how many different times, this kick and rush. Does anyone know what that means? Kick and rush. So somebody is kicking a philosophy out there, and as providers, what have we all done? We flock to it. And I've been, reading up on this thing called clinical equipoise, and it's true. And so we'll talk about thrust manipulation for the lumbar spine. If you're a PT that does not want to do thrust manipulation about the lumbar spine, what do you immediately think about a paper that shows its benefit?
Skepticism.
Skepticism. Absolute skepticism. And when you start to think about, well, I'm a manual therapist, what am I going to think about a study that looks at maybe spinal stabilization, right? But I would say, open your horizons a little bit. And when you see that data, take a look at it and judge it for what it's probably worth. In this particular paper here, again, what was the patient's primary complaint? Activity-related labor. And since this came out in 2017, so I would ask, I used to teach the spine, but I had to give it up just because it's administrative stuff. But I would ask, what's the differential for activity with first-year students? Activity-related labor. What would they tell me? Neurogenic and vascular blockage. Right? So this guy had activity-related leg pain for 30 years, they say. And he went through all these different paradigms, right? Back in the day, there was the Michigan State stuff, right? Where it was a lot of positional faults and you were doing muscle energy and different therapies to kind of correct those. Spinal stabilization came about. Dr. Joe Montana, I think, was at the 80s, right? That's when things kind of went hog wild on that. Right, he saw a McKenzie therapist, right, with leg pain, and he actually gave the patient more low back pain, right? And he thought, what? Oh, it's centralized. Your back's getting worse, but that's okay. That's okay. No, it wasn't okay. And then what did he become? Chronic pain, central sensitization type patient, cognitive behavioral therapy, pain counseling, etc. And I think things have shifted back a little bit. Like we did a talk at AM, I want to say before COVID, did it with Ron Schenk, that little lab component associated with it. And they asked us specifically, are you actually going to touch the patient in this talk or not? Because it went so far a few years back that PTs weren't even touching patients, right? It was this cognitive behavioral stuff. We turned into Dr. Phil for a while and he stopped touching patients. So this all went on in there until a PT said, well, let me take a look. I'll do my ankle brachial index and see what comes up. And that showed that he had significant claudication, right, in his lower extremities that was related to his symptoms. Now, that should have happened a heck of a lot sooner than it did. And, I put this up here because I know a lot of healthcare systems look at these, it's true, they look at these quality metrics. They look at them. Did you guys read this one? I thought this was interesting too. that what's the ultimate metric that a patient would care about? Can you make me better, right? Or my level better? That's all they really care about. Did you guys read this one? Here is a young person with Down syndrome who started to have rapid change in his behavioral patterns, right? Violence, outbursts, right? Thought he had some psychosocial stuff going on, put him on a myriad of medications for that. I think he gained about 90 pounds. And then they wound up moving, and they talked about, they wound up seeing a physician, multiple physicians who had seen this young person, and what actually shook out. It was a physician who was board certified, but she wasn't at the top of any of these, they were at the Cleveland Clinic, it wasn't a Cleveland Clinic physician, right? But it was a physician who had taken a particular interest in patients with Down syndrome behavioral changes. And what did they determine with this young person? Celiac disease, that's right. So it was a physician, again, who took a particular interest, right? She wasn't someone who's gonna, someone, but in their particular population, right, of friends that they had, this trend had developed, where they noticed these young individuals with Down syndrome having these behavioral issues that were related to that. Put them on a gluten-free diet, what happened? It got better. And so I think what it relates to is that, again, and we're not physicians, things aren't always as clear cut for us, but I think that if you're having patients who aren't getting better, you gotta try and figure out why. Don't just dismiss it to somebody else and think they're gonna fix it. We show you the data, but that's just not the case. All right, I'm gonna take another break, and then we'll come back and talk a little more about prognosis, because that leads right into a lot of our screening, the response to the opportunity score. Any questions so far? Questions at all? Parting shots? All right, let's go ahead and take a break. We'll come back at 25 minutes.